Thank you so much, Christoph, and good evening, everybody. It is a great pleasure and honor to be here today. So I think I have only 10 minutes. I think I don't have much time. So this is the outline of my talk today. I will briefly talk about HCC, and actually, I was introduced as a radiologist, but I'm a hepatologist, and I work for both hepatology and radiology, and I'm interested in HCC. So we'll talk about HCC and image quality and CUS LiDARs as it was introduced. I will share with you some cases and conclusion. So HCC is the 6th most common cancer and 2nd leading cause of cancer death worldwide. It is the fastest growing cause of cancer deaths in the United States, and it's tripling, right now. And, I'm sure in your practice you're seeing more HCC. Risk factors are hepatitis B in worldwide, and hepatitis C is the #1 cause in the United States right now. Now, cirrhosis of any etiology is also a risk factor, and NASH, or non-alcoholic steatohepatitis, is rising and will be the #1 cause of HCC liver mortality in the near future, and which is associated with obesity and metabolic syndrome, which is a problem for ultrasound. So ASLD and other liver societies recommend HCC surveillance in at-risk patients, and which is any patient with cirrhosis and specific population with hepatitis B. Ultrasound is the preferred surveillance tool, and that is based on randomized controlled trial and cost-effective analysis. Surveillance interval is 6 months. That is because of doubling time. Now, performance of ultrasound for early HCC detection is reported to be sensitivity of 63% in the meta-analysis, but varies 23 to 91%. So we know ultrasound can be operator-dependent, patient-dependent, machine-dependent, and we also know obesity is a known factor for poor quality ultrasound. So I will share with you some images that we scanned recently with Toshiba I-Series. And these are, so left hand, that's a BMI 30 obese patient, and then the right hand is a morbidly obese patient with BMI 40. And you can see, BMO grayscale, it's very nice, homogeneous images throughout the depth, and also very nice penetration. You can also see color Doppler and SMI, which is not moving. It's moving. Very nice microvasculature information. So now I want to talk to you about LiDARs. Now, in this audience, how many have heard of LiDARs? So some have heard of LiDARs. Now, how many use LiDARs? A few. Okay. So LiDARs is a liver imaging reporting and data system supported and endorsed by the ACR, and it was initially released in 2011. And it is a standardized terminology interpretation and reporting for CT and MRI of liver in patients at high risk for HCC. Lumason, or Sonoview in Europe and other countries, was recently approved for liver imaging in the United States. So we formed a ultrasound LiDARs working group in 2014, and we just released the first version of CUS LiDARs in August. And we are working on LiDARs 2017 version right now. So this is how it looks like. Oh, we lost the LiDARs. That's not good. And the current version looks a little bit different, but the table, this diagnostic table is the same. And LiDARs is basically, LiDARs 1 is definitely not malignant or benign lesions like hemangiomas or cysts. LiDARs 5 is the definite HCC that is almost 100%, there's nothing 100%, but almost 100% sure that is an HCC that you can send the patient to surgery, surgical resection, transplant, chemotherapy. We do not do biopsy when imaging says this is LiDARs 5 or definite HCC. And LiDARs 4 is a probable HCC. We actually, because the specificity is so important for LiDARs 5, we have the other HCC probable HCC that's included in LIDAS 4. And also LIDAS M is a somewhat atypical, and it could be HCC, but it could be cholangial, or it could be metastasis that is included in LIDAS M. So LIDAS M requires biopsy, and so that's how it works. So just look at this briefly, the table. So we look at this arterial phase enhancement. There's enhancement or no enhancement. We look at the size, and then we look at this washout. And I will explain to you in the next slide how we define washout on the contrast ultrasound. But to qualify LIDAS 5, it has to have arterial phase hyperenhancement, has to be greater than 10 millimeter in size, and late and mild washout. Then we can call it LIDAS 5. We can do surgery, we can treat as an HCC without biopsy. So not like CT or MRI, which in a CT or MRI, we just look at the presence of washout, and then of course they have capsule appearance and other ancillary features. But in a CEUS, we not only the presence of washout, we look at the timing of washout, and we also look at the degree of washout. So the timing of washout, early washout is less than 60 seconds, late washout is later than 60 seconds. And then when the lesion starts washing out, then we need to look at the degree of washout. Is it a mild washout, or is it marked washout, or punched out, very black washout? And to diagnose LIDAS 5 or 4 or 3, depending on the size and arterial enhancement, it needs to have a late and mild washout. Other ones are classified to be LIDAS M. Again, HCC can be in the LIDAS M category, but we want to be specific when we call it LIDAS 5. So I will share with you some cases we scanned recently with Toshiba I-Series, and this is a 50-year-old man with a 3.5 centimeter liver lesion in the left lobe right here, hypoechoic, the heterogeneous lesion. And you can see with the color Doppler and SMI, very vascular lesion, very hypervascular. It's very nice images, I like it, but can we diagnose this lesion? No, we can't. We need to inject contrast. And it's the same, it's not just ultrasound, CT, MRI, we need a contrast to diagnose those lesions. And so we injected a contrast, and that is Lumason. We injected 1.2 milliliter, and you can see very rapid enhancement, but we see from the peripheral pudding, and it's centripetal enhancement, and it's in a matter of 3 seconds, but because ultrasound real time, you can see that gradual, the enhancement pattern very well. And the lesion, hyperenhancing in the portal venous phase, and no washout in the phase. So this is a typical benign hemangioma. So this is another patient. She's 63 years old, alcoholic cirrhosis, and there's a 3 centimeter lesion in the right lobe of the liver, isoechoic, hypoechoic rim. It has vascularity. You can see with the color Doppler and SMI. What is this? We need to inject the contrast. So we did the injection, and you can see the beautiful feeding vessel and hyperenhancement in arterial phase, very homogeneous. And then we look at the washout. So portal venous phase, it's still enhancing. 2 minutes, it's still enhancing. And 3 minutes, you start seeing a mild washout. And 5 minutes, the washout progresses a little more. So this is a typical LIDAS 5 arterial enhancement, greater than 10 millimeter, mild and late washout. So this is an HCC. Another case, hepatitis C cirrhosis, a lot of ascites. There are some lesions. Right here you can see almost isoechoic, 2 lesions. By the way, we also did the shear wave, and despite the presence of ascites, cirrhosis, we could get a nice measurement. And then we, of course, injected the contrast. And the lesions, there are 2 lesions. They all both enhances very hypervascular in arterial phase. And these lesions do not wash out. So this is 2 minutes, and if I can convince you, 8 minutes, it's you know, we are losing contrast from the parenchyma, but the lesions are actually still enhancing. So these lesions are hypervascular and no washout. So these are LIDAS 4 lesions, but this is basically HCC. Like I said, LIDAS 4 can include HCC. Now, here's another patient, 25-year-old female with multiple liver lesions, again, enhancing, hyperenhancement in arterial phase, no washout. So is this LIDAS 4? We cannot apply LIDAS in no high-risk patients. She's 25, she doesn't have cirrhosis, she doesn't have hepatitis B, and this is in fact hepatic adenoma. So we need to be careful, you know, the population is actually very important. And so it's basically enhances like HCC, you know, focal nodular hyperplasia enhances from, like Dr. Fisher showed, the beautiful, beautiful FNH. Spoke wheel adenoma is more from outside to inside, like HCC. And last case, a similar case, 75 years old, hepatitis C cirrhosis, the arterial phase. It's hypervascular. You can see, again, the feeding vessel, beautiful hyperenhancement in arterial phase. Very, very sensitive to contrast. That was my impression using the first time Apio I series. And mild washout in 3 minutes and 5 minutes. So this is, again, LIDAS 5. So to conclude, ladies and gentlemen, HCC is a common cancer and acutely rising in the United States. Ultrasound is recommended for HCC surveillance in high-risk patients. Image quality is fundamentally important for surveillance and in a workup for focal liver lesions. And CUS LIDAS helps to standardize terminology, interpretation, and reporting in diagnosing focal liver lesion in high-risk patients for HCC. Thank you very much.